For those of you who I have not yet met, my name is Brittany. I am one of the PGY2 AmCare residents, and today I'm going to present on giant cell arteritis, or what I will refer to as GCA, throughout the presentation today. And I would like to thank my content expert, Shelby Gomez, for her insight regarding this topic. I have no disclosures or conflicts of interest. Our objectives today are going to be, first, understanding the epidemiology and pathophysiology of GCA. Then we're going to review the 2021 ACR guideline recommendations for the treatment of GCA. And finally, we're going to analyze clinical trials assessing new treatment options for GCA. Let's start off by introducing our patient, SJ, who we will be talking about throughout the presentation today. SJ is a 75-year-old female. She presents to the emergency department with headache, jaw pain, fever, and blurred vision. She has a past medical history of polymyalgia rheumatica, diagnosed a few years ago in 2020. Polymyalgia rheumatica is an inflammatory rheumatic condition characterized by symmetrical aching and stiffness in the shoulders, hips, neck, and torso. She also has a history of H. pylori and atrial fibrillation. As for SJ's family history, her father had CAD and a history of MI, and her mother had type 2 diabetes. SJ is a former tobacco smoker. She quit about 30 years ago. Next, let's tackle Objective 1 and talk about the epidemiology and pathophysiology of GCA. As for the prevalence, GCA is the most common idiopathic systemic vasculitis involving large and medium vessels. It affects about 20 per 100,000 persons per year and has a lifetime risk of about 1% in women and 0.5% in men. Risk factors for GCA include age. The incidence of GCA rises steadily after the age of 50 and peaks between ages 70 to 79. Approximately about 80% of our patients with GCA are 70 years of age or older. Gender is also a risk factor, so females are 2.5 times more likely than males to be diagnosed. Persons of Northern European and Scandinavian descent are also at greater risk. There is increased risk for persons with comorbid polymyalgia rheumatica as they have shared disease processes. Environmental exposures like tobacco exposure, infection, as well as genetics are risk factors. However, we do not routinely screen for HLA genes associated with GCA like we might do with some other disease states. And lastly, uncontrolled diastolic blood pressure may also be a risk factor for GCA. You may be wondering what causes GCA, so let's break down the pathophysiology of the disease. There are dendritic cells, which are present in normal arteries, and they can be activated in GCA through pathogen or damage-sensing receptors. These danger signals, or toll-like receptors, lead to production of chemokines and cytokines. Once the dendritic cells are activated, CD4 T cells, which are our helper T cells that assist with immune responses, they also then are activated and polarize into Th1 and Th17 cells. And these are our specific types of helper T cells, and they secrete different cytokines, including interferon gamma, tumor necrosis factor, IL-17, and others. And this step leads to inflammation. Through the additional activation of cytokines and chemokines, there's additional recruitment of T cells, including more CD4 T cells and CD8 T cells, as well as monocytes, which are a type of phagocytic white blood cell. The CD8 T cells are the cells that induce death by either lysis or apoptosis. At this step, the monocytes are going to differentiate into macrophages, and the macrophages merge to form these multinucleated giant cells, which is the hallmark of GCA. This step leads to remodeling of the tissue. So this progressive inflammation and remodeling, tissue destruction, and formation of these giant cells leads to narrowing of the vascular lumen. And in turn, this reduces the amount of blood and therefore oxygen or other nutrients that is able to reach the body's tissues. As for prognosis of GCA and goals of treatment, GCA is a medical emergency, and as such, it should be treated as soon as the diagnosis is suspected because it can lead to blindness. Prognosis is dependent on intensity of symptoms at onset and the speed at which treatment is started. Most studies have found that life expectancy is not or is only marginally reduced in GCA compared to age-matched populations, with the exception of a subset of patients who go on to develop large vessel complications. Care for giant cell arteritis focuses on protecting the patient's vision, limiting end organ damage, and reducing treatment toxicity. Our patients are likely going to be presenting with either cranial or extracranial symptoms. The most common cranial symptoms of GCA are persistent, severe head pain, usually located in the temple area, scalp tenderness, jaw pain, especially when chewing or opening of the mouth, and then vision loss or double vision. This can progress and lead to sudden permanent loss of vision, and blindness can occur in 15 to 20% of our patients despite treatment and is usually irreversible. So again, highlighting the importance of starting treatment as soon as possible. Common extracranial symptoms include fatigue and muscle pain, low-grade fever, and potentially some unintended weight loss. GCA can cause more serious complications, including cranial ischemia, which are things like blindness, which we already discussed, but also stroke, which is typically uncommon in GCA, but can be a complication. And then patients may also have large vessel involvement. So things like aortic aneurysm, which may form due to the weakened blood vessels. This usually can occur years after diagnosis of GCA, so a doctor may monitor the patient annually with imaging to ensure that there is no large vessel involvement. Patients with GCA are also at a fourfold higher risk than age-matched controls for myocardial infarction, and patients can also have limb claudication, which is just pain in the extremities due to poor circulation. So this leads us to how GCA is diagnosed. Based on the 2022 American College of Rheumatology and the European League Against Rheumatism classification criteria, the patient must be at least 50 years of age. And you'll see here on the table that this is an absolute requirement for the classification of GCA. Additional clinical criteria are listed here. All of the symptoms we previously discussed. So morning stiffness, sudden visual loss, jaw pain, new temporal headache, scalp tenderness, and abnormal examination of the temporal artery. You can see here that vision loss is scored higher than some of these other clinical criteria. Additionally, laboratory and biopsy or imaging are important in diagnosing GCA. Blood tests may reveal elevated ESR or CRP, which are inflammatory markers. And imaging may also be done to see if there is bilateral axillary involvement or aorta involvement. The gold standard test for diagnosing GCA is a temporal artery biopsy, which you'll see here listed second below the laboratory imaging section. And if it's positive, it is likely to be a definitive diagnosis. And you can see here that the temporal artery biopsy is going to be scored 5. So After scoring your patient, you would sum the score, and a score of 6 or more is needed for the classification of GCA. Let's talk about pathology and imaging a little bit further. So I mentioned that the best way to confirm diagnosis is by doing a temporal artery biopsy, which is usually about 1 centimeter in length. And this artery is situated close to the skin, just in front of your ears, and continues up the scalp. The procedure is performed on an outpatient basis using local anesthesia and only causes minimal discomfort or scarring for the patient. If the patient does have GCA, the artery will often show inflammation and includes those abnormally large cells or giant cells, which give the disease its name. It is possible, however, to have GCA and have a negative biopsy result. The specificity of the temporal artery biopsy is up to 100%, but the sensitivity can be as low as 39%. And that's primarily due to poor sampling on biopsy and the presence of large vessel disease, which is associated with less of this temporal artery involvement. If the biopsy is negative, the provider may proceed with non-invasive vascular imaging like CT scans or ultrasounds. And once the patient is diagnosed, it is recommended to go on and complete these non-invasive vascular imaging anyways to evaluate if the patient has any large vessel involvement. Okay, time for a question for the audience to see what we've learned so far. Remembering that SJ is a 75-year-old female who presented with headache, jaw pain, fever, and blurred vision to the emergency department. Given her symptoms, the provider suspects GCA. The provider does not initiate treatment and schedules the patient for outpatient temporal artery biopsy to be completed in 1 to 2 weeks to confirm diagnosis. As a pharmacist working on the team, do you have any concerns? A, no concerns, as the temporal artery biopsy is the gold standard for diagnosis. B, yes, you have concerns for vision loss. C, no, you do not have any concerns. You need to confirm diagnosis before starting treatment. Or D, you have concerns as ultrasound and MRA are the gold standard for diagnosis. So if you could just put your answers in the chat, and I'm not sure if I'll be able to see the responses, so Allie, if you could please read them off, that would be wonderful.
Sure, I'll let you know when people start putting in answers.
Thank you.
All right, I'm seeing a lot of B's, Britt.
Thank you. So that is correct. B is the correct answer. You do have concerns as the provider did not start treatment. And remembering that the prognosis of GCA is dependent on the speed at which treatment is started and reduces the risk of complete vision loss. And we know that SJ was preventing with some blurred vision. Let's move on to Objective 2 and review the 2021 ACR guidelines for the treatment of GCA. I will add that the EULAR also has guidelines available, but given the more recent ACR guidelines, this is the standard of care that we use in the United States. The ACR guidelines break down treatment into different buckets. So we have initial treatment for those newly diagnosed or at presentation. We have treatment once the patient is in remission. There are also other therapy considerations we're going to talk about further, and some patients may also need surgical intervention. Here you will see a snip from the ACR guidelines. Initial treatment decisions are dependent on if the patient has visual symptoms or critical cranial ischemia. If the patient does have these symptoms, they will require high-dose IV pulse steroids followed by oral high-dose steroids in combination with tocilizumab over just the steroids alone. In some instances, the provider may consider methotrexate instead of tocilizumab. On the right-hand side here, for patients without any visual symptoms or cranial ischemia, those patients will require oral high-dose steroids with tocilizumab over steroids alone. And again, in some instances, the provider may use methotrexate instead of tocilizumab. So the big difference here is confirming if the patient has cranial ischemia or visual symptoms, because if they do, they will require IV steroids. The reason why we use steroids is that they help prevent vision loss and reduce and control inflammation by triggering a decrease in the level of IL-6, and they inhibit T cell activation, proliferation, and polarization into Th17 cells. Again, we have two different routes of administration. We have oral, which is conditionally recommended, and then we have the IV pulse dosing, which is recommended in patients with threatened vision loss. Patients may be on steroids for up to months and even years. The duration is not well established and is really based on the patient's clinical manifestations and how well they're tolerating the steroids. If the patient is to receive IV pulse dosing, they're going to receive this for 3 to 5 days and then transition to the high-dose oral steroids. After the first month of being on therapy, the provider may gradually begin to taper to the lowest effective dose. During this period, some symptoms, particularly like headache, may return like during that tapering period, and such flares may be treated with slight increases then in the steroid dose. Patients can typically start to see improvement within a few days of starting steroids, remembering that it's unlikely that any vision-related symptoms are going to improve. And of course, we all know the side effect profile for steroids, especially with chronic use. So we should definitely be aware of that and monitor our patients closely. If our patient has comorbid diabetes or osteoporosis, for example, we may try to minimize treatment duration as much as possible and may even consider attempting a quicker taper. For the completeness of this presentation, I also included dosing. So typically we will start either prednisone 60 to 80 milligrams daily or IV methylpred at 1,000 milligrams daily. Next, let's talk about tocilizumab, or otherwise known as Actemra, which was the first approved treatment for GCA in May of 2017. The GACTA trial was a multi-center, randomized, double-blind, placebo-controlled study that looked to evaluate the efficacy and safety of tocilizumab in participants with GCA. The study consisted of 2 parts, the first part being a 52-week double-blind treatment period, and then part 2 followed, which was a 104-week open-label long-term follow-up period. So part 1 is shown in this table on the slide. Eligible participants were randomized to receive either tocilizumab 162 milligrams weekly or tocilizumab 162 milligrams every 2 weeks, or placebo. And they also all received oral doses, daily doses of prednisone. At 26 weeks, tocilizumab weekly and biweekly were both statistically significant for sustained remission compared to placebo. However, at 52 weeks, only tocilizumab weekly was found to be statistically significant in sustained remission. So tocilizumab has steroid-sparing effects as well, so it is recommended to be used with steroids in those newly diagnosed over using steroids alone. It is an antagonist of IL-6, which is induced by inflammatory stimuli and mediates a variety of immunological responses. There are both IV and sub-Q formulations. The sub-Q formulation comes in a prefilled syringe and an auto-injector device. IV dosing is dosed 6 to 8 mg per kg once every 4 weeks, and the sub-Q formulation is dosed at 162 milligrams once weekly, and that is really based off of the findings of the GCA trial and is why we choose weekly over every other week. You may know that in rheumatoid arthritis, choosing weekly or every other week is based on a patient's weight. So that is something that is unique with Actemra use for GCA. We may consider the 162 milligrams every other week for hepatic or hematologic dose adjustments. Patients may start to see improvement within 1 month of treatment and continue to see full benefit up to 3 months. Common side effects of tocilizumab include constipation, hypertension, hyperlipidemia, injection site reactions, and hematologic changes. As you may have guessed from the hepatic and hematologic dose adjustments and side effect profile, tocilizumab does require baseline lab and routine lab monitoring. Baseline labs include a TB screening, a Hep B and C screening, CBC with DIF, LFTs, and serum creatinine, and a lipid panel. There are parameters set for ANC, platelet, and ALT and AST for when Actemra should not be initiated, which you'll see listed here. Routine labs include a CBC with DIF, LFTs, which are drawn 1 to 2 months after starting, and then every 3 months thereafter, as well as lipids 1 to 2 months after starting, and then every 6 months thereafter. I listed here as well when you would want to discontinue treatment based on any lab abnormalities. Tocilizumab also has a black box warning for serious infection risk as it is suppressing the immune system, and it's contraindicated in a history of diverticulitis, a history of GI perforation, and active malignancy. There are precautions for hepatic effects and increased risk for cardiovascular disease. The other medication we may choose in some circumstances is methotrexate. For most, we will choose tocilizumab over methotrexate, given its steroid-sparing effects. There are no head-to-head comparative studies between tocilizumab and methotrexate with results currently, but the steroid-sparing effects seen with methotrexate has been shown to be smaller than in that seen with tocilizumab. Methotrexate can be considered in those who are unable to tolerate tocilizumab or those who have limited access to the drug. I did want to highlight a few studies that are important to consider. The GCA trial did have a part 2, which I mentioned previously, and they looked at adults with active new onset GCA or refractory GCA without sustained remission at the end of part 1, so at the end of 52 weeks. Patients were randomly assigned to receive tocilizumab weekly plus prednisone or placebo plus prednisone. And methotrexate could be initiated at screening in the double-blind period at the investigator's discretion. The preliminary results suggest that adjunctive methotrexate does not increase the likelihood of sustained remission, reduce relapse rates, or improve steroid sparing. And the response to tocilizumab appeared to be independent of methotrexate. The second trial listed here is a meta-analysis of 3 randomized controlled trials of patients newly diagnosed with GCA, comparing high-dose steroids and methotrexate to placebo and steroids. The meta-analysis found a statistically significant reduction in relapse with methotrexate compared to placebo, and also found a statistically significant reduction in cumulative steroid doses. And then the last trial listed here is currently recruiting participants, and it's going to compare tocilizumab to methotrexate head-to-head with outcomes looking at relapse rates and comparing economic consequences, so things like access or cost. It'll be really interesting to see what the results are for this trial and if it changes any guideline recommendations. As we know, methotrexate is a folate antimetabolite that inhibits DNA synthesis, repair, and cellular replication, and it also inhibits T cell proliferation and thus the ability to produce cytokines. There are oral and sub-Q formulations that we may be considering for our patients, starting at 10 to 15 milligrams once weekly and adjusting their dose by 2.5 milligrams a week if needed based on the patient's response as well as tolerability. Common side effects include GI side effects like nausea, vomiting, diarrhea, and oral ulcers. Dermatologic side effects like rash or photosensitivity, as well as hematologic toxicity and hepatotoxicities. We do add folic acid daily to patients on methotrexate to reduce the risk of adverse effects. Patients likely start to see initial response to therapy 3 to 6 weeks after starting and can see a full response up to 3 months after being started on therapy. Methotrexate does require monitoring, so we're going to need to get baseline labs, including a CBC with DIF, LFTs, serum creatinine, and a Hep B and C screening. Labs should be monitored again 7 to 10 days after initiation, then 2 to 4 weeks after for the first 3 months, and then every 3 months thereafter if the patient's stable. We should monitor if a patient has current infections and if therapy needs to be interrupted. We should also use caution in patients taking NSAIDs, PPIs, or those requiring live vaccination. And methotrexate is contraindicated in pregnancy, liver disease, and any pre-existing blood dyscrasias. Here, you'll see another snip from the ACR guidelines. So let's talk about how we treat our patients once they reach clinical remission. If the patient does reach clinical remission, we should then attempt to taper the daily steroid dose. Typically, we taper the steroids 15 to 20 milligrams per day within the first 2 to 3 months, with the goal of being on less than 5 milligrams per day after 1 year. Some clinicians may also consider tapering off the tocilizumab or methotrexate. If the patient's not in clinical remission, we would consider adding or changing the non-steroid immunosuppressive agent. So if they're not currently taking tocilizumab or methotrexate, we would consider adding it, or if they're not responding, we would consider changing it. You can see here that this decision tree is the same no matter if the patient was initially treated with IV steroids or not. You'll also see listed here at the bottom abatacept, which may also be considered if these other agents are not effective. The guidelines don't go into much detail. They just mention that if these other agents are not effective, that it may be a consideration. However, I will talk more about this near the end of the presentation when discussing medications in the pipeline, as abatacept is currently being studied and is in phase 2 clinical trials. Unfortunately, patients with GCA may relapse, and if they do, we have 2 options. We can, one, either increase the steroid, which is common, especially if our patients are having polyrheumatic symptoms only, so things like aching and stiffness or headache. And typically we increase to the last effective dose unless there is a major relapse. So thinking things like cranial ischemia, progressive vascular inflammation, or even vision involvement. And in those more serious cases, we would restart steroid therapy based on new onset disease. So those high dose oral steroids or IV if there's vision involvement. And the second option is to add immunosuppressive agent if they're not already on one, or change the non-steroid immunosuppressive therapy if it's not working. And that's particularly important to consider in patients who have multiple recurrent disease relapses, as we can assume that therapy is ineffective. There are some additional therapies that may come up while treating a patient with GCA. Statins, which are widely used in prevention of cardiovascular disease, may come up for potential use in GCA, especially considering our patients may have large vessel involvement and are at increased risk for MI. However, the role of statins in GCA is not clear, and based on current literature and guideline recommendations, we should not be using statins unless there is another indication. Baby aspirin, on the other hand, when taken daily, may reduce the risk for ischemic events in patients with critical vascular narrowing. And the efficacy remains unclear in patients with GCA, but it may be considered at an individual basis. Additionally, these patients are going to be on steroids chronically, so it is important to monitor their vitamin D and calcium levels and supplement when necessary. It's also good to have routine DEXA scans to monitor and evaluate their bone health. Other suggestions to help patients manage their condition and cope with the side effects from medications to prevent bone loss, diabetes, or even high blood pressure is eating a healthy diet. So things like fruits and veggies, whole grains, limiting salt, sugar, and alcohol intake, and then also exercising regularly. Additionally, some of our patients may require surgical intervention. For patients with worsening signs of limb or organ ischemia who are receiving immunosuppressive therapy, it is recommended, however, to escalate the immunosuppressive therapy first before proceeding with surgical intervention. And the reason is that patients can develop collateral blood vessels to improve distal blood flow. We may consider immediate surgical intervention, though, for those with aortic aneurysms at high risk for rupture or progressive organ damage despite escalation of immunosuppressive therapy. So we're thinking things like angioplasty, stent placement, or vascular procedures. For patients who do undergo vascular surgical intervention, it is recommended to use high-dose steroids during the periprocedural period if the patient is having active disease, which if they are proceeding with surgical intervention, they likely have active disease. Okay, so now for some more questions. So remembering that SJ presented to the ED and the provider suspected GCA. The provider did not initiate treatment. However, you had concerns for vision loss given the patient's complaints of blurred vision and wanted to initiate treatment immediately. After addressing your concerns with the care team, which treatment option is the most appropriate for SJ at this time according to the 2021 ACR guidelines? A, high-dose IV methylpred and tocilizumab. B, high-dose oral prednisone and tocilizumab. C, high-dose IV methylpred and methotrexate, or D, high-dose oral prednisone and methotrexate.
Seeing some A's, Britt, in the chat.
Great. So A is correct. So because SJ had vision involvement, we would want to choose IV steroid formulation over the oral formulation. And then it is recommended to start tocilizumab with the steroid over the steroid alone. And then lastly, C and D would be incorrect because tocilizumab is recommended to be used over methotrexate given its steroid-sparing effects. So 2 years have passed since SJ presented to the ED. Doctors have now confirmed her diagnosis of GCA. Her symptoms have been stable on prednisone 10 milligrams daily and now methotrexate 10 milligrams weekly. So she was switched from tocilizumab to methotrexate because she was not able to afford it. Today, SJ presents to the clinic with headache, muscle pain, and stiffness. What is the most appropriate next step? Do we A, want to increase the prednisone to 40 milligrams daily with a taper regimen? B, increase methotrexate to 12.5 milligrams weekly? C, taper methotrexate and initiate tocilizumab, 162 milligrams sub-Q weekly? Or D, start IV methylpred for 3 to 5 days and then resume oral steroids?
A couple A's in the chat, just 2 so far.
Okay, I'll give it a few more seconds.
A guess of B.
Okay, well, let's talk about it a little bit further. So A is the correct answer. SJ is presenting with mostly those polyrheumatic symptoms, so things like muscle pain, stiffness, and headache. So it is recommended to increase oral steroids in those circumstances of the more mild relapses. B is incorrect because we would not want to increase the non-steroid immunosuppressant right away. We would want to increase the steroid, as the steroid is going to have quicker action to treat more of those acute symptoms. We know methotrexate takes a little bit longer to work. However, when the patient follows up with the provider to taper the steroid, they may consider increasing methotrexate at that time so that they're able to taper the steroid. We may also consider switching to an alternative non-steroid immunosuppressive agent like option C. However, we know that the patient was unable to afford tocilizumab. And also, it's important to think about the fact that the patient has been stable for some time, and we might consider switching in cases of more recurrent relapses. And then D is incorrect because there was no signs and symptoms of major relapse, so thinking cranial ischemia, progressive vascular inflammation, or vision loss that would require the IV methylpred. Now for our last objective, let's briefly analyze clinical trials assessing new treatment options for GCA. The GCA pathophysiology is complex and multifactorial. Science has shown a lot of promising therapeutic strategies to target for the treatment of GCA, and this figure depicts the main drugs approved or under evaluation for the treatment of GCA, highlighting their main therapeutic targets. So you can see here JAK inhibitors are a potential target, acting on step 2 of GCA pathophysiology when the CD4 T cells are activated and polarize into Th1 and Th17 cells. You'll also see a beta sept here at the top of the figure, which inhibits T cell activation by binding to CD80 and CD86, which we'll talk a little bit more on the next slide, as it is mentioned in the guidelines as potential treatment. So abatacept, which is a T cell blocker, is currently in phase 2 clinical trials, looking at the safety and efficacy of abatacept versus placebo for those with GCA and TAC arteritis, which is a disease that has common overlap with GCA pathology. You will see a p-value listed here of 0.049, which reflects the comparison of relapse-free survival of abatacept versus placebo in GCA specifically. The other two drugs listed here are JAK inhibitors. So we have Rinvoq, which is in a phase 3 clinical trial. The trial is a 2-period trial, the first looking at safety and efficacy with a steroid taper compared to placebo, and the second looking at safety and efficacy of continuing treatment versus stopping treatment in those that are in remission and if remission is maintained. And then we have baricitinib, which is in a phase 2 clinical trial looking at relapsing GCA and the safety and effectiveness of it in this patient population. Unfortunately, there are no results posted for either of these 2 trials. And then we have Cosentyx, an IL-17 inhibitor, currently in phase 3 clinical trials, looking at the safety and efficacy of Cosentyx versus placebo with steroid taper in new onset GCA and in clinical remission. We have Tremfya, an IL-23 inhibitor, currently in phase 2 clinical trials, looking at the safety and efficacy of treatment versus placebo in new onset or relapsing GCA. And then the last one listed here, mavrilimumab, is a medication that's not yet FDA approved. It is currently in phase 2 clinical trials looking at the safety and efficacy versus placebo in new onset or relapsing GCA. And this is exciting because it is a new drug target, so it selectively blocks granulocyte macrophage colony stimulating factor. So some exciting things in the pipeline for treatment of GCA. Key takeaways for this presentation include GCA is caused by inflammation in the lining of arteries and is a medical emergency. It most commonly affects women aged 70 to 79, and it is treated with high-dose steroids. Temporal artery biopsy is the gold standard for diagnosis, and there are many drugs currently being studied for the treatment of GCA. So that is all I had for today's presentation. I will open it up for questions. If you do not have any questions, I hope you were able to learn something and hope you have a great rest of your Tuesday. And I also put up the text to sign in code if you missed that at the beginning of the presentation. Thank you.